Greetings from Chicago. I'm Katie Kompoliti, and I'm going to spend the next half an hour talking about dysautonomia in MSA. More specifically, I'm going to talk about orthostatic hypotension, bladder dysfunction, constipation, and erectile dysfunction. Let's start with orthostatic hypotension. So how do we achieve blood pressure control? And this is based in a large part on the autonomic nervous system, as well as an elaborate network of receptors, nerves, and hormones. The autonomic nervous system can be subdivided into the sympathetic and parasympathetic nervous systems. And all this is a primitive part of the nervous system in humans, and a lot of times it operates beyond our will. So the sympathetic nervous system represents the fight and flight response, which raises the blood pressure, and the parasympathetic nervous system represents the rest and digest part of our life that lowers blood pressure. And here you can see the sympathetic and parasympathetic nervous systems, one in green and one in orange, and the systems they affect. And this is basically the whole body. So what happens when we have orthostatic hypotension? We have a sustained decrease in systolic blood pressure of 20 millimeters of mercury, or a decrease in diastolic blood pressure of 10 millimeters in mercury within 3 minutes of standing, and that's when compared to the blood pressure from the sitting or supine position. So it happens when the person changes positions, especially if they do this suddenly. So the orthostatic hypotension can be subdivided into the neurogenic orthostatic hypotension, which is we're going to discuss mostly today. But we can have orthostatic hypotension because of low blood volume, drug side effects, and other causes. And these are issues that we need to address when we're trying to optimize the blood pressure. The neurogenic orthostatic hypotension can be a sign of diseases of the central nervous system or the peripheral nervous system. And when it's a consequence of problems in the central nervous system, one of the major diseases that are the culprit is multiple system atrophy, as opposed to the peripheral nervous system, where a major disease there is Parkinson's disease and neuropathies, especially diabetic neuropathies. So what does the person experience when we have drop in blood pressure upon assuming the sitting or upright position? First of all, we have non-specific symptoms like weakness, lethargy, fatigue, falling, nausea, or leg buckling. We have other symptoms that are very common because of decrease in cerebral perfusion, not enough blood get into the brain, and these include dizziness, lightheadedness, presyncope, syncope, that means loss of consciousness, cognitive difficulties, and headache. And then we have blurred vision because of retinal hypoperfusion. The person can get pain, especially pain in the neck and shoulder, which is usually called the coat hanger headache. And if we decrease perfusion to the heart, we can get chest pains, angina. And when we decrease perfusion to the lungs, we can have shortness of breath upon assuming the upright position. So what happens when a person goes from laying down to standing? More than half a liter of blood shifts to the lower body. Under normal circumstances in a healthy subject, we have compensatory mechanisms, including the sympathetic nervous system with release of norepinephrine, adrenaline, which maintains the blood pressure by constricting the blood vessels, thus pushing the blood up. Thus, we maintain cerebral perfusion. In a patient with neurogenic orthostatic hypotension, these responses do not work as well, and that's part of the disease involvement, and thus the person has the symptoms we mentioned before. So if we look at a full day of an individual, in green, we have a normal individual, then they have mild fluctuations in blood pressure. And at night, when you go supine, when you hit the pillow, the blood pressure goes down only to elevate in the morning. In a person with orthostatic hypotension, the blood pressure goes up and down during the day in a dramatic way. And when you hit the pillow at night, it goes sky high. And that's the so-called nocturnal hypertension or supine hypertension. So we are dealing with a roller coaster, which is not good for everybody. It's bad for the patients and gives the doctors a headache. So here is another way to look at it. What are the things that contribute to this? First, you see that meals tend to have a tendency to lower blood pressure. You have a dip in the blood pressure here with every meal. And the red is the systolic blood pressure and the blue is the diastolic blood pressure. And at night, when the person gets up to go to the bathroom, you have this severe decrease in blood pressure that can make people pass out in the bathroom at night or on the way to the bathroom. And when they get out of bed in the morning, it's the worst time in terms of orthostatic hypotension. So this is something that needs to be treated. And so how do we address it? First of all, we look at the medication list and we discontinue the medications that are causing it beyond the disease causing it. So all those are the blood pressure medications. So the person does not need blood pressure medications anymore. Some of the old-fashioned antihypertensives tend to do that. Cialis, a lot of the erectile dysfunction medications can cause precipitous drop in the blood pressure. Some of the bladder medications, tizanidine, a muscle relaxant, can be particularly bad in causing this. Then we have the conservative non-pharmacologic measures, and we're going to talk about that in more detail. And finally, we have pharmacological treatments. Let's start with lifestyle, physical activity, and meals, the non-pharmacological measures to address orthostatic hypotension. An individual should avoid hot, humid weather, hot showers or saunas, prolonged bed rest during the day, physical immobility, high carbohydrate meals, i.e. meals with high glycemic index, daytime alcohol, exercise in a recumbent or seated position, rowing or stationary bike is good, as opposed to standing, treadmill. Exercise in a swimming pool is good. And also smaller meals, more frequent meals are good, especially if they include carbohydrates with low glycemic index. And here you see which foods have a high glycemic index and which foods have a low glycemic index. And the second approach is volume expansion. So the person should avoid alcohol and caffeine, avoid sugary beverages, encourage increased fluid intake up to 2.5 liters per day, encourage salt liberalization, and encourage acute water bolus. If somebody feels fainting, drinking acutely 500 mL of water can raise the blood pressure for 40 minutes. Finally, some physical maneuvers can contribute or worsen the blood pressure drop, and that's straining with the closed glottics, like when you strain to have a bowel movement, and that's called the Valsalva maneuver. And that should be avoided. Encouraging changing positions gradually is a good thing to do. Encouraging briefly sitting before standing, not jumping out of bed. Leg crossing, standing on tiptoes, stooping, squatting, buttock cleansing increases the blood pressure as well. Finally, compression garments can work and getting the blood pressure high, but knee-high compression stockings do not work. So the person, if you're going to go and do that, you have to wear waist-high compression stockings, 15 to 20 millimeters of mercury. Abdominal binders are an alternative approach. They're easy to get and they can be worn as needed, not the whole day, i.e. that you can wear them after a big meal, for example, when you know that you're going to take your Parkinson's or your medication and have a big meal and you expect the blood pressure to drop. How do we ameliorate supine hypertension, the increase in the blood pressure people have at night? This is present in 50% of NOH patients. It's worse early in the morning before we get out of bed. And once you get out of bed, because of the chemical changes that happen in the body, if the blood sugar is too high, you have pressure diuresis, you go to the bathroom a lot and you deplete a lot of your volume and then you pass out. So we need to elevate the head of the bed 30 degrees, and this should be in a straight way, not with compressed middle of the body. People need to eliminate nighttime meals and sweets. There should be no pressures less than 4 hours before bedtime, and the person should eliminate short-acting antihypertensives at bedtime. And a person, sometimes, if you need to, you can use short-acting antihypertensives at bedtime, and there are some of them listed here. And these are short-acting, so by the morning, they're out of your system. So what medications then these are medications to lower the blood pressure at night when needed, but most of the time we need medications during the day if the conservative measures fail to maintain the blood pressure. So the patient feels good and we have room to increase the medications, which also can drop the blood pressure. So the only medications that are FDA approved are midodrine and droxidopa or Northera. We have 3 more medications we're using, but these are also what we call off-label. Florinef or fludrocortisone increases water and sodium reabsorption from the kidney, increases the intravascular volume, so it wouldn't be a good thing for people with heart failure, increases blood pressure in all positions. Higher doses than more than 0.2 milligrams per day do not improve therapeutic effects and only intensify side effects. So you start with half or 1 pill, you can go up to 2 pills, but that's it. And you don't need to spread the dose morning and afternoon. It works by giving it once a day. Side effects include swelling of the ankle, low potassium, potential for left ventricular hypertrophy if you stay on it long enough, or renal failure. It should be used for short periods. And then we have medications that enhance the sympathetic nervous system and work at different levels. You see here, you have the central nervous system, and then you have different parts of where you have communication between with the synapse and the postsynaptic membrane, and then you have the blood vessel. All this is a message that goes through to the blood vessel from the brain through a lot of chemical and electrical signals. So we intervene with midodrine, intervenes on the wall of the blood vessel by constricting the wall of the blood vessel. Atomoxetine, that's midodrine, and droxidopa work by enhancing norepinephrine. Droxidopa produces a precursor to norepinephrine, and atomoxetine prevents the norepinephrine from being taken back up in the presynaptic membrane, so makes it more available when we need it. And ampreloxetine is similar to atomoxetine. And ampreloxetine is the compound we're starting a trial soon for NOH and MSA. Pyridoxystermin, which is a secondary drug, acts on the parasympathetic nervous system. And that's another, as I said before, is secondary to other medications. When all of the other medications fail, we add it on. So midodrine was introduced in 1996. It's very short acting, but it shoots up. It has a very fast peak effect after 1 hour. And side effects are supine hypertension. So it shouldn't be taken less than 3 to 4 hours before bedtime, before you lay down. And it can cause these other side effects. But the main one is it can cause a lot of supine hypertension, and perhaps it's the worst in terms of supine hypertension. Droxidopa was approved in 2014. In Japan, it's been approved since 1989, and it's short-acting, but the peak effect is not so fast as the midodrine, so it tends to cause less supine hypertension. It's a smoother peak effect. So this has the best response in patients with low norepinephrine. And again, the side effects are supine hypertension, but less than the others. And finally, we have the norepinephrine reuptake inhibitors, which is the atomoxetine, which is currently available, and it's an ADHD medication, and ampreloxetine, which is we're starting a trial soon for MSA and has showed promising results. The ampreloxetine is longer acting than the atomoxetine. So, as I said before, when you have peripheral autonomic lesions, like is the case in Parkinson's disease, you have low norepinephrine. And that's when you have a better response to droxidopa. In multiple system atrophy, which is a central lesion, you have high norepinephrine, so you have a better response. Theoretically, you should have a better response to atomoxetine and ampreloxetine than droxidopa. So, and then we have mestinon, which, as I said before, enhances the parasympathetic nervous system and has modest effect when used alone. It has synergistic effect when used with midodrine or atomoxetine. So moving on to bladder involvement in MSA, bladder involvement manifests itself as urinary frequency, urinary urgency, and urinary incontinence. And this presents as urge incontinence and as bedwetting at night. So the bladder function so the bladder by itself acts as storage of urine. And the second function is voiding. So it fills up, and then it contracts and empties. So when you store the urine, you have bladder muscle relaxation and the contraction of the sphincter, so you don't have leakage. And when you void, you have contraction of the bladder muscle and relaxation of the sphincter, so you void. So the bladder involvement in MSA is the sole manifestation of MSA in 18% of the patients. Its onset is 2.8 years prior to motor symptoms. Both urine storage and emptying dysfunction occurs. In early disease, you have overactivity of the smooth muscle and external sphincter weakness. In advanced disease, you have retention. And as I said before, one characteristic that's actually part of the definition of MSA is post-void residuals. And when you have more than 100 ml of post-void residuals, you have clinically established MSA. Or if you have any volume of post-void residuals, you have clinically probable MSA. And then there are little variants of that, but with less strong evidence to support the diagnosis of MSA. So how do you treat bladder symptoms? You treat it by retraining the bladder, by timing frequent voiding intervals, and pelvic floor PT shouldn't be underestimated. And then you have medications, and you have to be careful. Anticholinergics are used, but that can produce some cognitive problems. Perhaps Sanctura or Tropsium is the least likely to produce cognitive problems. And then the best ones probably that don't produce a drop in blood pressure or cognitive problems is the mirabegron or Mibredic. And then we can do botulinum toxin injections, nerve stimulation, intermittent self-catheterization, or a permanent Foley catheter sometimes, or a suprapubic catheter. Then you have some bladder irritants you should avoid, and that always helps. And then these include alcohol, citrus juices and fruits, very spicy fruits, caffeine, carbonated beverages, sugar, honey, corn syrup, artificial sweetener, and smoking. Moving on to constipation. Constipation is a disordered movement of the stool through the colon or rectum. And it can be due to disease, or for some people can be part of who they are, or can be due to drugs. So this is something you need to minimize, the other drugs that could intensify constipation. And how you treat constipation, first with non-pharmacological measures, by increasing fiber intake, fruits and vegetables, special diets like bran, Activia probiotic yogurt, prune juice, fermented foods like sauerkraut or kimchi, exercise. Squatty potty helps a lot, and it's very easy to get through Amazon, and we cannot underemphasize water, good hydration. And then you have pharmacological agents, and they work in different ways, either by forming bulk, or by softening the stools, or by promoting of water secretion in the bowels, or stimulating the bowel to move faster. This we use less frequently, or the newer ones that work on different chemicals, like the serotonin promoters, or fatty acids like amitisa and linzess. And finally, exercise can treat constipation. And one small caveat here, not everybody can do this pose, but there is an exercise in general should be utilized. Finally, erectile dysfunction can happen for many reasons besides neurological diseases or MSA, and that it could be psychogenic, it can be hormonal, it can be because of vascular or arterial problems, as is the case in atherosclerosis, diabetes, and hypertension. Or it can be drug-induced. As I said before, some of the older antidepressants, some of the antipsychotics, some of the antihypertensives on anti-androgens can cause erectile dysfunction. I'm sorry, the older and the newer antidepressants. Or other systemic diseases and aging can contribute to erectile dysfunction. But for our purposes, we're talking about central effects, and in MSA, the problem is mostly central, but the other factors can coexist. So how do you address that? You have to be careful, because a lot of the medications we use for erectile dysfunction can cause a precipitous drop of the blood pressure. The Cialis, Viagra type of drugs can make the blood pressure go down very fast and precipitously. So one has to consult with their doctor before using them. And this is the end of my presentation. And we will be glad to entertain questions in the question sessions. Thank you very much.